minute, we are bringing you live Stemi India 2018 from Lucknow. It's great pleasure to introduce Dr. P.P. Mohanan. He is Director and Head of Department of Cardiology, Westfort Hospital, Thrissur, Kerala. So welcome you. So let me begin with the questions that what is the role of newer antiplatelet therapy in STEMI management?
Well, the dawn of 21st century has given us a quite lot of newer molecules, which has helped us in sort of treating STEMI patients to a greater extent pretty well. And one of the conventionally we have been using the dual antiplatelet drugs, which involve the aspirin and clopidogrel. Aspirin, we have plenty of data right from for centuries, more than 100 years, we've been using aspirin, and the antiplatelet dose of aspirin is anything between 75 to 325 milligram. Generally, we use 75 to 150 milligram. We have also some data which has come recently, which show that if one uses an intravenous preparation of aspirin in the dose of 250 to 500 milligram, it may be better than the conventional oral dose of aspirin. But then oral, make it a point to use a chewable aspirin. That is the most important part of aspirin. Now come to the second drug. We have been using clopidogrel for all these years, maybe about 3 or 4 years prior. But of late we are aware of the deficiencies of the potency of clopidogrel, the interaction with the other drugs, and the slow responders, the huge proportion of slow responders, and that paved the way for the newer generation of P2Y12 in antiplatelet drugs. And the initial to come was a drug called prasugrel, and this particular drug was superior to clopidogrel in STEMI management in forms of better efficacy, and even though since it is a more potent drug, it causes more bleeding. Then came the third drug called ticagrelor, which is not essentially a thienopyridine, but a P2Y12 inhibitor, a non-thienopyridine reversible P2Y12 inhibitor, which when compared to clopidogrel give you a substantial improvement in mortality. Even for the first time, an antiplatelet drug has shown a total mortality reduction. So that has not happened with the other drug, and this has only happened with ticagrelor. Even though there are no direct comparison between prasugrel and ticagrelor, the various pharmacodynamic studies, network meta-analysis, even systematic analysis shows that maybe ticagrelor is a better drug than prasugrel in cases of STEMI management. It may not be. We don't have an absolute proof of that, but this is the general practice. But we have also an intravenous thienopyridine, a P2Y12 inhibitor in the form of cangrelor, but this is not a class 1 indication, it's a class 2A indication, which may be of use especially in a person who has not been loaded with aspirin or conventional earlier, is suddenly coming to the cath lab for a primary angioplasty, and you have generally the oral drugs take some time. So if you use an intravenous drug like cangrelor, they may have its use in a small subsets of patients. So that is the scenario of the antiplatelet drugs in STEMI.
So, sir, what could be the role of new anticoagulants in the STEMI management?
As you rightly said, the anticoagulant, you have two limbs of the hemostasis process. One is the platelets on one side and the coagulation cascade on the other. So antiplatelets, very important. Then comes the anticoagulants. Conventionally, we have been using heparin. Last many years we have heparin with its efficacy and its attendant complications like bleeding and other. At times, people develop heparin-induced thrombocytopenia. And later we have the low molecular weight heparins, and we have a lot of data on enoxaparin amongst the low molecular weight heparins, which is better than heparin. But if you look at the guidelines, it is still heparin, and enoxaparin is given as a class 2 indication. Especially it may be useful in situations where, especially when you have a fibrinolysis patients, then maybe enoxaparin can be used better. There is a third drug like fondaparinux, which we uses, but not in the cath lab. Fondaparinux has its value in STEMI patients who undergo fibrinolytic treatment. The newer molecule called bivalirudin came with a lot of excitement about 5 or 6 years ago, and we have initial data which showed that it scored over heparin. If you compare bivalirudin on one side and heparin plus the 2B3A antagonist on the other side, people showed that bivalirudin has better efficacy, better safety. But later, what I have seen, there are a lot of 5 or 6 randomized controlled trial has shown that these advantages of bivalirudin, which is shown in the initial data, is not there. So bivalirudin right now is confined to small groups of patients where you cannot use heparin. Right now in the cath lab, in the STEMI management, the principal anticoagulant use these heparin and at times enoxaparin.
Thank you so much for sharing this view on newer treatment therapies for the STEMI management. Sir. Thank you so much for being here with the STEMI.